koutou katoa, no te amana o Katupuna, no te amana aho, ko Elba te awa, ko Koko te manga, ko, where is he, John? Aku takutane, ko Siro rawa Daphna, aku tamariki, ko ana Ranta toko ingwa, no reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you everyone for coming today. It's a special event, it's a special day. It's World Stroke Day today, and this event is in honor of maybe not celebrating, but raising awareness for stroke globally and in Aotearoa, New Zealand, and in Wellington. It's also an opportunity to celebrate a little bit of the achievements that have come out of Wellington right here. And so I wanted to take this opportunity to tell you a little bit more about what's happening here at home and abroad. So I will talk about what a stroke is. Actually, I'm going to have moved that a bit further down, so last minute slide adjustments. Stroke in Aotearoa and globally, stroke prevention, novel risk factors that you may not be aware of, stroke diagnosis and treatments, and then some more on stroke innovations here and abroad with some concluding remarks. Now, I give a lot of lectures and I try to make them funny. So there's not a lot of humor in this, I have to admit. I Googled stroke and joke and I got this. So it's a bit sobering. Stroke is definitely not a joke, and I'm not trying to make a joke of it. So let's talk about why stroke isn't a joke. Why is it so important? Well, it's the second most common cause of death and disability globally. 1 in 4 of us will have a stroke, and we all know someone with stroke. I just want to highlight the recently launched campaign, We All Know Someone from Stroke Aotearoa, and I just wanted to see a show of hands. Who here knows somebody with stroke? Just about everybody. So it is common, and it is also common in the young. So 25 to 30% of people with stroke are under the age of 65, and we're spending more than $1 billion a year on stroke in Aotearoa, and it's getting worse. As in we're getting more strokes. We're not necessarily increasing the incidence of stroke, that's per population, but our population is aging and our population is growing. So the burden of stroke in our country is increasing, and that's a prediction I made, invited by the Ministry of Health to do a report almost 10 years ago, maybe 7 or 8 years ago, and we've done an interim analysis. It's not quite as bad as predicted, but within 8 years we had an increase of 17%. Now some of that was because of COVID. We had reduced hospitalizations, people just didn't go, so there's some hidden illness here. We know not everyone with stroke presents, but we're definitely not decreasing our strokes. The good news is we're getting better at treatment. So this is a graph of what we call reperfusion therapies. I'll talk more about that a little bit later on, so you don't need to, if you don't know what that means right now, don't worry about it, but these are treatment interventions, and you can see every year we're increasing our treatment interventions. So we are keeping up with treating stroke, but we need to do more to prevent stroke. And then I just want to mention the Regions Care Study, and Steph Thompson was my PhD student during that project, which looked at outcomes after stroke. So we've talked about incidence and growth and burden, but how do people do after stroke? And just to orient you to this graph, so these are little slots of the light gray is you're completely fine at 12 months, and dark gray is you've died at 12 months. So these are the brackets, and we compared New Zealand European versus non-New Zealand Europeans and urban presenters and non-urban presenters. So these are people presenting first to a non-urban hospital in New Zealand versus an urban one. And then in green is the difference. These are the people who are independent at 12 months. And this, I'll translate this to you. So basically what this means is if you're presenting to a non-urban hospital, you're only 3/4 as likely to be independent at 12 months. This is right here in Aotearoa, New Zealand. Perhaps more shocking is if you're non-European, you're only just over half as likely to be independent at 12 months. So this data is now 7 years old, and we have done work since then, and we'll have to reevaluate, but I'll tell you a little bit about some of the things we've been doing. But first, I want to come back to stroke prevention. So what can we do to reduce the upfront burden of stroke? And what are some of the risk factors? So I've given stroke lectures for 25 years, and I used to always start with aspirin and those kinds of things. And now I've turned it around and first talk about lifestyle. Because if we improve our lifestyle collectively, we'll actually have the biggest impact on reducing the stroke burden. And this starts right from childhood. And we're increasing our focus on getting children to have a healthy lifestyle, so it's embedded in their life for the rest of their life, because we all know it's hard to change when we're adults and getting older. I'm certainly finding it challenging. We're all battling with this, and motivation is our biggest enemy. enemy? How do we motivate to not smoke, to not eat salt, to not eat sugar, to eat more vegetables and fruit, to drink less alcohol, to exercise more and sleep more? So this is a slightly more novel risk factor, although we've known about it for a while, that we know that if you get good sleep, you have lower risk of stroke. But the two that I really want to talk about is blood pressure and atrial fibrillation. So blood pressure is really, really important. It is the single most treatable cause of stroke globally. And we now know the lower the better. So do you remember the target of 140/90? That's out the door. We no longer talk about 140/90 blood pressure. We want 120/70 or even less. The lower, the better. I was in Barcelona last week at the World Stroke Congress, and yet another paper presented that if we lower the blood pressure, you have reduced recurrent risk of hemorrhagic stroke. And this is a really good investment. If you don't have one and can afford one, I've got one. I have high blood pressure because I'm stressed. It's like $100. Really, my GP told me that. It was like the most useful advice my GP gave me. I went right out to the pharmacy and bought one. It's brilliant because it gives you visibility of where you're at. And if you don't need one, maybe someone in your family needs one. So that's a portable blood pressure device. Atrial fibrillation is an irregular heartbeat, and I'll tell you a little bit more about how that causes stroke a little bit later on. We do ECGs in doctors' offices and in hospitals, but there are all these devices now. So if you can afford a smartwatch, figure out how, it's not easy, but figure out how it can pick up irregular heart rhythms. And if you don't need one, maybe your parent needs one. My parent needs one. My dad has IF. I diagnosed him last Christmas when I visited him. He wasn't feeling well. He said he had a heart attack, and he didn't. And I checked his pulse, and he had AF. So AF is very common. It gets older. It gets more as we get older. And the reason AF is so important is because it doesn't only cause stroke, it also causes heart failure, dementia, and death, and it's so treatable. So we can give blood thinners. Everyone's always scared of blood thinners, of rat poison, if you heard of that. Warfarin was rat poison. It's like not a good sales pitch for a drug. We now have non-rat poison blood thinners. They work really, really well, and they're very safe. We looked at people in the same study that Steph led. We looked at people who had a stroke on blood thinners and stroke off blood thinners who had atrial fibrillation. And there were more bleeds, brain bleeds, than the people who had atrial fibrillation and were not on blood thinners than were on blood thinners. So it is a low risk of bleeding complication. It has complications, but please don't judge it before you know a little bit about it. And I won't talk about lowering cholesterol and managing blood sugar like diabetes much more than mentioning it, but I just wanted to mention them because they're also important. What I wanted to talk a little bit more is about some of the novel risk factors that you may be less familiar with and some of my recent research in that space. So I've become very interested in environmental factors of stroke risk, and especially air pollution. So air pollution is actually now slowly creeping up on hypertension as the leading cause of stroke globally. And there are countries where air pollution is the biggest risk factor for stroke. So air pollution is a really big problem. There are other environmental factors also relating to climate change. So you may not think climate change, how does that relate to stroke? And I didn't think it related to stroke. It was actually my kids. I was trying to convince them to do something useful with their lives. And they're like, well, you don't do anything useful with your lives. And I was like, what should I do? It's like, well, you got to do something about climate change. I'm like, oh, God, I'm a stroke neurologist. There's no link. And then I said, well, I'll have a look. And it turns out there is a link. So there's a link with increasing temperatures, there's increased humidity changes, variabilities, changes, heat waves, also cold spells. There's a whole number of climate-related changes, and we're just finishing an International Journal of Stroke scientific statement for the World Stroke Organization on this topic. And I could spend a whole hour just on this topic. So there are some complex interactions and compound weather events, but it's very interesting. Even just flooding. Even if it doesn't cause a stroke directly, the disruption of infrastructure, if you had stroke risk, you can't access your medicines, it's a problem. So we need to be prepared. And I've started this sort of as a joke, and now I've become like this world expert in stroke and climate change. I've written this policy statement, and I'm doing this international statement. So there's sort of serendipitously these things happen. The other part why I got interested in is because I really like tramping. I like being in the woods. And my other daughter said, one time we were in the woods, we're like, why does it make you feel so good to look at a mountain? I'm like, I have no idea, but it does, right? Who doesn't feel good in the woods, right? We feel good in the woods. So I wanted to look into that. And there's evidence that it reduces stress and it improves mental health. And there's this whole concept from Japan of forest bathing. There's rehab studies where they've done rehabilitation in the woods and seen better long-term outcomes for people who were exposed to the nature during their rehabilitation. And so it's a burgeoning topic, and I've been quite interested in this. Now, my current PhD student did a study in New Zealand using health administrative data. We didn't see a benefit in stroke incidence and mortality in New Zealand, but I suspect we're just so spoiled with green space that we don't see the difference, but more work to come. Now, I want to talk about 3 other emerging risk factors. One is microplastics. Who here has heard about microplastics? Yeah, okay, so you know. So there is an increasing suspicion of linkage with microplastics and stroke, that the particles enter the bloodstream and cause changes to the vasculature and increase the stroke. So we're looking at doing some studies around that. It's an emerging field, but we're all a bit worried about it, aren't we? And that filters into that entire, like the environment. You know, we always talk about personal risk factors, and we're increasingly thinking, well, maybe it's not all on us. Maybe it's on society. Maybe we need to create healthier environments for us and change how we're looking at things a little bit. There's a little bit of victim blaming with saying, oh, you're overweight or your blood pressure is high. Well, why is my blood pressure high? Maybe it's because I get all the sugar and salt in my processed foods, you know? So it's a little bit changing the dialogue. A couple other ones that are just kind of interesting to note are kava. So I've spent some time in Fiji. And they've done audits, and people who consume kava seem to have higher risk of stroke. And my recent time in PNG, I learned about the betel nut, and betel nut chewing also seems to confer a bit of an increased risk of stroke. So these are just sort of emerging things that I thought you might find intriguing. Moving on to stroke treatment. So before I can talk about stroke treatment, we need to all understand what a stroke actually is. Now, you're all very informed, and I was thinking, you know, I give a lot of lectures to academics and, and sometimes patient groups, and there's a little bit of a mix here, so I hope not too boring, but we just need to all be on the same page. So stroke is loss of brain function due to the disruption of blood supply to the brain due to either something called ischemic stroke, which is a blockage. Does my thing work here? So here's is a blood vessel. This happens to be called the middle cerebral artery, and there's a blockage there. And so blood flow is disrupted to this part of the brain, and it's starved of oxygen and nutrients. The brain can survive that for a wee while, just like we can survive holding our breath underwater. But if we are not with oxygen for long enough, eventually we will not survive. And this part of the brain may not survive or will not survive after sufficient time has passed. Now, what causes these clots? So we have vasculature throughout our whole body. And in various places in the body, we can get these plaques to build. So these are atherosclerotic plaques, and they are built because of high blood pressure that disrupts the blood vessel wall. When the blood vessel wall is ruptured a little bit, it's exposed, and underneath it, it's sticky. And things like platelets, which are blood products that aspirin inhibits, platelets and cholesterol stick to it. And that's why it's yellow, because it's mostly cholesterol. So it's cholesterol and platelets stick to the vessel wall, and then what happens, it eventually closes off. And then you have a blockage. That sort of blockage is called a plaque and happens in small blood vessels sort of far into the brain. It can also happen in the bigger blood vessels in the brain, but what happens more commonly in the bigger ones in the neck, the carotid artery, you've heard of that one, is these plaques are really big, and it's quite a big vessel. For that to close, it's a lot of plaque. What happens instead, the plaque ruptures. So another bit of high blood pressure, and the plaque opens up and just throws these little emboli up into the brain. So these little puffy balls, they move up and eventually get to a blood vessel that's so small that it gets stuck. That's called an embolic stroke, or a artery-to-artery embolus. Now, the other big cause is atrial fibrillation, which I've already talked to you about. And so atrial fibrillation is a problem with the heart. It's an irregular heartbeat people get after they've had heart attacks, or actually alcohol increases the risk of atrial fibrillation, other causes as well. And what happens in the heart, the heart doesn't pump regularly, a bit of the blood stagnates. When blood stagnates, like when you cut yourself, it stops flowing, it clots. It's supposed to, so if we cut ourselves, we don't bleed to death. But it's not supposed to happen in the heart. Because in the heart, when you build clots and then you pump again, that clot then travels up to the brain and gets lodged in one of the blood vessels. So those are the two ways, the two most common ways that we see blockages in the brain. And then we have hemorrhages. So hemorrhages is a burst blood vessel, and that can happen through two mechanisms. Either you have just the high blood pressure erodes that blood vessel wall and it gets all a bit cruddy and then it just ruptures, like a really old garden hose. Yeah, eventually it just ruptures. And then there are people who have aneurysms. So that's these outpouchings that build over time. It's, if you imagine a balloon, think of a little unblown up balloon. It's really thick wall. You blow it up, gets very thin. Add a little bit of pressure and it ruptures. So that's what happens to aneurysms, which are hereditary and sometimes they're spontaneous. So the bleeding, when you get bleeding, so the blockage starves the brain of oxygen. The bleeding expands and pushes on structures around it, and you're inside a skull, so there's not much room. So eventually you run out of room and you start pushing on things and create damage. So what can we do to reduce the immediate damage from these things? Well, the first thing for blocked blood vessels, we want to unblock the blood vessel. It's not rocket science, right? For bleeding, we want to stop the bleeding, because if we can control the bleeding, it doesn't keep growing. And then what I haven't talked much about is mini strokes, which are just transient events that then go away. So you have a little stroke symptom that lasts maybe a few minutes, or more typically half an hour to a few hours, goes away, you think you're fine. But the risk is, of course, that you get a recurrence. And all of these things are urgent, because the longer you wait, the bigger the bleed is, the less salvageable tissue there is behind the blockage, and the more likely it is you'll have another event that's bigger and doesn't stop. So how do we go about treating? Well, the first thing is we have to diagnose the stroke. Now, diagnosis of stroke isn't actually that straightforward, and not most things aren't straightforward in medicine. Now, we think we're really complicated and smart in neurology, but we get accused of that a lot. But so the brain is a little bit complicated, I might just say that. Now, the heart is probably also really complicated, but at least we have an ECG and we have blood tests. With the brain, it's a little harder. And who is the first person? So what we do is we know what part of the brain causes what symptom. We see what symptom the patient has, and we relate it back to the brain structure. Now, stroke actually in some ways isn't a brain problem, it's actually a blood vessel problem. So we don't just locate it to one part of the brain where all these things happen in the brain, we locate it to a vascular territory. So these are the vascular territories, so each one of those blood vessels affects one of those areas in the brain. And we know the constellations of these symptoms. So if somebody has a set of symptoms, I can tell you it's that blood vessel. And by locating to one blood vessel, I know it's a stroke, because it's a blood vessel problem and it was sudden. So I make that diagnosis. The problem is, who's the first person who notices a stroke? Not me. I'm the end of the line. It's everyone else. It's the people with the stroke. So we need to simplify this because it is a little bit complicated. And so we've come up with this acronym called FAST, which simplifies it quite a bit to the most common and most significant stroke symptoms, which is facial droop, arm weakness, and speech difficulties. And of course, stroke Aotearoa and Ministry of Health, or Te Whatu Ora Health and Z, it's hard to keep track what we're calling it. But we've come up with this acronym. This is used worldwide. One New Zealand specific thing is take action. So the world calls it TIME. We found out that people didn't know what to do with that, and we changed it to take action, and there's been some evidence that people understand that better. So just a shout out to Stroke Aotearoa. So we call the ambulance, but just a reminder, it is a simplified paradigm. It's for the lay people and paramedics who deal with a lot of other conditions as well. There are a whole bunch of other things that can be a stroke when they occur. The problem is, when you have any one of those, it's more likely that it's not a stroke. And so it's like weighing that risk-benefit. That's where people like GPs and emergency doctors and A&M doctors are very important. Okay, so that's what happens in the pre-hospital space. So you call 111, you come to hospital, and now it's time to unblock the blockage. So we have these options. So this is what CT, this is what imaging looks like, right? So you've got your ischemic stroke. This is an MRI scan, so isn't that great? Like that everyone can tell something's wrong there, right? Except we don't get that acutely, so we don't have that luxury. This is also an MRI scan of a much smaller stroke. But this is what we usually get, which is just the plain CT scan, which tells us nothing other than there's no bleed. So we haven't gotten the diagnosis. So we still rely quite heavily on that clinical diagnosis. But what can we do? We want to reestablish the blood flow. And this is the only opportunity we have to actually reverse the damage. Everything after this is recovery and reorganization of brain tissue. So there are two types. There's clot-busting drugs or intravenous thrombolysis. We have to give this within 4.5 hours of symptom onset. That is not a lot of time. It might be okay if you're in Newtown. But if you're in, Ratahi, you're a little bit out of luck. So you got to go to Wanganui, and do you get there? And then you might need to come to other places. So being regional, or Kaitaia, I've met some people in Rabane, Hokianga, they're really far away from a hospital. And then there's this other thing. So we use the alteplase, is the old drug. We now use a drug called tenecteplase. And then there's stroke clot retrieval, which we do when we have this blockage, right? So we think, oh, where's my mouse? So we have this blockage, we have this image. We don't really know what's going on, but we do this other thing called the CT angiogram. So that's a newer imaging modality. We look at actually the blood vessels themselves. And if somebody has what we call a large vessel stroke, so a large territory, we then look for a blockage. Now, I don't know if you can appreciate this, but this is a CT angiogram. Here's this thing called the circle of Willis. This is a really healthy middle cerebral artery, and then here it just stops. Do you see that? But that's the blockage. So we want to open that up. And we can use this thing called clot retrieval. So we can go up with a catheter and pull it out. So we go up, we feed it in the groin. It goes through the aorta, past the heart into the carotid artery, into the brain, all the way up. We've had clots that are so far that the catheter doesn't reach. In big men, we sometimes have that problem because it's too far away, but usually not. So we go up to we have the little chicken wire thing that you can see. We place it around the clot. We let it sit there. We let the clot coagulate, bind to the chicken wire, and then we gently pull it out. So we actually physically, it's like a corkscrew. So in fact, they originally tried corkscrews. That didn't work very well, but this works better. That's the blockage. So that's how we unblock things. So intracerebral hemorrhages, that's what this looks like, much more obvious. So this is the same scan I showed you before, the one we couldn't really see anything on. This is a CT. It's in every hospital in New Zealand, or at least in every secondary hospital. And you see that big white thing? That's a hemorrhage. That's blood in the brain. And so that's easy to spot. And we want to lower the blood pressure, but also within 6 hours, because it's the blood pressure that caused the bleed in the first place. So you have your garden hose again, you turn down the pressure, the bleeding stops. It turns to a trickle, so it doesn't expand anymore. So we want to pull out the blood from the blood vessel to let it heal, because it's as long as the spouting happens, it cannot heal. It needs to pull back, and then it self-heals. Our body is great at self-healing, but we have to create the right environment. And then more new on the block is minimally invasive brain surgery. So we've been trying brain surgery for eons. It seems attractive, like why don't we just take it out? The problem is, to get to that, you have to dig through a lot of brain, pull it out, and cause a lot of damage. So sometimes the patients are worse off than before the surgery. But minimally invasive surgery now exists. We're still learning about it in New Zealand, but we can insert this tube through a small incision, minimally damaging the brain tissue, and then inserting another catheter in there and sucking out the blood, then putting a bit of water or saline in it to expand it, to have a look around with a camera to see where the bleed is, cauterize the bleed, wash it out a little bit more, pull the tube out, and it shrinks, and it just has that line, so much less damage. So this is the first kind of intervention for hemorrhages that really seems to make a difference in selected patients. And then there's this other bleed, that's subarachnoid hemorrhage. That's not bleeds into the brain. This is blood that stays around the blood vessel. So the blood vessel eventually enter the brain, but first there's just sort of in between the brain lobes, and it bleeds and it causes headache and looks a lot like a migraine. So these thunderclap headaches, we talked about it earlier, that's aneurysms. And those, we also lower the blood pressure because, again, it's bleeding, right? You want to reduce the pressure. And we coil these. So have you heard of coiled aneurysms? what we do, we used to clip them. We still clip them occasionally, where the surgeon actually opens it all up, identifies the little outpouching, remember the balloon I talked about, and just sort of puts it literally like a staple, clips it across. And then blood cannot go in there, and then cannot rupture. It's like tying off the balloon. Can't put any more air into it. And so the new technique is, again, like we do the clot retrieval with the catheter up to the brain, and we just throw these little metal coils in there, or plastic coils, and then blood coagulates to it, and it just clots off. Or we put a stent, like a little tube, a little wire tube, across the opening, so blood cannot get through it. So those are the two options we have. Okay, now I have one slide which is horrendous, and I have some colleagues here from the stroke unit. So I'm an acute neurologist, so I'm going to just live my best me and talk about acute stroke neurology. There's a lot that happens after all of this. So my game is to prevent strokes and to treat them and make them not have problems afterwards. But some people do still have problems. And so we need to admit people to acute stroke units where we have multidisciplinary care, and we prevent secondary complication, which is where nursing comes in, and is really important to prevent your pneumonias, to prevent your clots in your legs, to prevent constipation, urinary retention. All of that sounds not very important, but it is actually what causes death and stroke. It's not actually the stroke. It's the complications that cause the demise and the poor recovery. So we want to do early rehabilitation, getting people out of bed, mobilizing them, and we want to do in and outpatient rehabilitation. And again, mention Steph, my dear friend, we just recently managed to finally get our paper published that found that community rehabilitation, if we can get people home faster, outcomes seem to be better, as long as they're able to go home. Some people are just so disabled they cannot. But I say this because some of you, and I've heard this when I talk to consumer groups, I was kicked out of hospital. It's like, well, it's actually good for you to go home. Why is it good? We don't really know, but we think, well, don't we all want to be home? I would say there's something a little bit strange with people want to stay in hospital. But, if you're home, you do stuff. You get up, you get the mail, you make yourself a cup of tea. When you're in the hospital, we have this model where just people lie in bed in a gown, like it's not normal. And lying in bed in a gown is the worst thing you can do after stroke if you can get up. So you're more motivated to do so. You're also more motivated by your environment, by your family, by your friends, by things that give you meaning. There's this Take Charge After Stroke intervention that was developed here in New Zealand, first with Maori and Pacific patients, that showed that sort of goal setting with things that matter to patients, not walking 3 steps, although that is important, but longer, lofty goals. Want to go on the boat, want to go to the Moana, like something that is meaningful to you, connect with nature, is actually what gets people motivated and do stuff. And then there's life after stroke. And again, I've done many, many focus groups with people with lived experience, and I do a lot of co-design. It's very rewarding. And those people who have disability, that's their life for the next 30 years. And that's what people talk about in these focus groups. It's a little bit of a bias sample, because if you did well and don't have a problem, you probably move on and don't think about your stroke. If you haven't had that luxury, that's what's important to you. And so we try to support, and again, Stroke Aotearoa, that's the bread and butter. Okay, now we're going to talk about some innovations. Some of them not so recent, and some of you I know me and seen this before, but this was my PhD project. This is now a long time ago, like 10 years ago or so. And it's a decision support tool for GPs, and one of my GP colleagues is here as well, which is lovely. I developed it back when I was in Palmerston North working with David, and the idea is that the GP needs to diagnose strokes, mild strokes and transient strokes, and know what to do with them. And as I said earlier, it's not always easy to diagnose it. So this is sort of a pocket guide. You can tick some boxes, sort of almost like an early kind of AI tool, except it's not quite AI, and I'll talk more about AI in a minute, but it's an algorithm. It's a mathematical algorithm that gives the GP a likelihood of whether it's a stroke or not. So it gives an output and then gives treatment advice. And so the idea was that we treat the right patients at the right time in the right place and give them the right treatment. And the earlier we do it, the better. We published this and did a randomized controlled trial. And just having this tool in GP practices reduced a 90-day stroke risk by 71%. So there's a really massive reduction in vascular events, and we're very lucky that the Ministry of Health funded it for national rollout. We've just done an update of the tool, and it's now going to be linked to the national radiology pathway, so that if a GP finds the result and wants to do CT in the community, they will have access to that. Okay, now a couple other things that are a bit more into the past. So Stroke Foundation, now Stroke Aotearoa, did a national stroke audit in 2009. Now I showed you those treatments we do, the reperfusion treatments for the blocked vessel, right? The clot busting and the clot retrieval. At that time, we had no clot retrieval, only clot busting. Less than 3% of stroke patients received that treatment. So that was pretty shocking to everyone. So we said, okay, we better start something. So we started this national stroke network that came from Stroke Aotearoa with Ministry of Health. And one of the things we did is start a register. So we started capturing every patient who gets these treatments to see how well we're doing with it. And then what we did is we did fast campaigns to get people to come to hospital. So we raise awareness. So you wouldn't have seen fast campaigns in 2005. This started around 2014. And this actually had an impact. Then we started telestroke. So telestroke is something that was spearheaded in Wellington Hospital right here. And telestroke is to bring specialists to the patient in the regional centers where there isn't as much economy of scale, so they don't see as many volumes, not much expertise, no neurologists. And so the idea is that we just, now it seems really obvious, right? Like, why don't we just Zoom them in, right? Why don't FaceTime? You cannot believe how opposed people were to this in 2016. I was able to do this with somebody in Scotland before I was able to do this with somebody in Wellington. This was when I was in Palmerston North. But we got there. And so we started doing, this is my home situation. So this is what I do at night. I can see the patient. This is what I see at night, which is always very unpleasant. And then I can be about and see it on an iPad or a laptop. That was the early days. Now I can see it on my phone right here. And this is an IV pole in Wellington ED. The unit is stationed there, so I can do the Wellington patients from home as well. So some of you may have had a stroke and been assessed via telestroke. We are right there. We can see the patient immediately. Now we have our trainee student, and we're bringing up the next generation. So this, so this is the trajectory across the regions with these various interventions by year. And you can see where we implemented telestroke in the central region, across 8 hospitals in the central region, the bump it got. And that's all the regional hospitals. So with that, we've actually equalized care. So the intervention rates now, where there's telestroke, is as good if you present to Wanganui Hospital, or Wairarapa Hospital, or Tairāwhiti Hospital, or Taranaki Hospital as it is in Wellington. Now, then there's the story of clot retrieval. So clot retrieval was approved in 2015. That's where we pull the clot out. And you can see at the ones on the right, here, these are all hospitals in New Zealand. So every one of these is one DHB. Remember the DHBs, now districts. I'm not really sure why it's different, but we no longer have boards, I think is the main difference. But so these are individual hospitals. This is Auckland Hospital that contribute to clinical trials. These are the other 2 Auckland hospitals, Middlemore and North Shore. And this is what Christchurch. Thank you. Okay. This is Auckland, Middlemore counties, North Shore. This is Christchurch, and this is Wellington. These are the tertiary centers or in metro areas. And this is the rest of the country. And this will be like West Coast, Rotorua, those kinds of places. Abysmal, no access whatsoever. So we started a national stroke clot retrieval program with funding from the Ministry of Health and basically coordinated ourselves. That's all we did. We had no funding. We just talked to each other, cross-sector, cross-hospital, cross-region. We implemented telestroke in some more places. I had a meeting with the ambulance and inter-hospital transfer people. You probably don't know very much about this sector. It's very interesting. They're all men. They all like planes. And so there's like these inter-hospital transfer people that are from the hospital, and then there's the ambulance, helicopters, there's the ICU people, there's ED people, and they didn't like each other very much. It was like a very testosterone-driven thing, and we had this first meeting with these guys, and there's me, and then one of them come to me, he's like, I think that was the first time we were all in a room together. So like it's a funny, medicine is a funny thing. We have these fiefdoms. We all want the same thing, but somehow we end up kind of not talking to each other very well. And so literally coming together and talking and doing pathways. We had a consumer group. We had a lot of Maori involved in the consumer group. So we put all that together, and this is what we achieved. So this is the 8% mark we had set in 2019. By 2023, almost all hospitals were above 8%. So this is what can be achieved just with a bit of ingenuity and communication. It did not need a lot of extra funding. So that's kind of in the past. So let's talk about now and just a few things lying ahead. So I'm going to start from the pre-hospital space now. For people like you in the community, what's going to happen? How's the future going to look? Well, what's on the doorstep are things like this. What anyone thinks this might be. These are wrist devices. So just imagine I watch on, what do you call it? Apple Watch both hands. Why do you need it both hands? You're comparing to see if you have arm weakness. So the watch tells you if you're having a stroke. You're no longer reliant on you or your family member. It's a little sad because now you can just have a stroke alone, which is always sad. But at least it was an advantage to have your fan hour around. Now you're becoming so independent. It's great, of course. It'd be a great tool to have. They did market sort of consumer feedback, and people don't like wearing them on both hands. So it's like we're so married to having one device, which is sort of interesting. This is not yet really in use or in the market. I think they're selling it, but it's not been validated. This is equipment you put on your forehead at night. So you can wear it at night, and it looks at your EEG, your brain waves, and when you have a very large stroke, your brain waves reduce. So it can pick it up and sets an alarm, goes to a alarm, kind of like the bell you have if you're older and at home. You can have a call bell. You can also have this alert, go to ambulance to be called. And the bottom right is a facial recognition. So this is for consumers, but it's also for paramedics. So instead of looking to see if there's a facial droop, you hold that up, and the computer tells you if it's a facial droop. So it uses AI technology, same facial recognition we use on our computers now. And the last thing is monitors remember those plaques I talked about? So it monitors blood flow. It's an ultrasound type machine, and it monitors how much blood flow is going through, and when it stops, it tells you you've had a stroke. So it's these monitors for patients in the community. There are also things happening in the community, in the paramedic space. So we already have, this is already a thing of the current time, these mobile stroke units with CT scanners inside the ambulance. And that happens, it's like there's one in Melbourne, there's two in Berlin, there's one somewhere around Munich, there's one in Houston. They've got like 10 in Bangkok for some reason. I think they've just decided, Thailand has decided to invest into this. But mostly they're not really in existence because they're very expensive. They're very expensive to run because you have to have all these like CT tech, paramedic, and the doctor and everyone on the ambulance. So it's very expensive, and they don't have much reach. We have 20 or 30 ambulances in our area. We can't have them all be that. So the chance that the right ambulance is at the right area is pretty low. But some people think this is like the new, sort of best thing since sliced bread, and it is expanding a little bit. Some of these other things are EEGs. This is to differentiate an ischemic stroke, the blockage, from a hemorrhagic stroke, to be able to treat in the ambulance, to treat faster. Because remember, it's like holding your breath underwater. The faster we undo the blockage, the better. So this is kind of like the nighttime thing. It hasn't really been shown to be too effective. These are microwaves to check whether you have a hemorrhage. And this is an MRI scanner, a portable MRI scanner. We're actually working with Walloomia. It's a Wellington company. That we're working in Hospital Wellington now to try to validate this portable MRI scanner. That, out of all these things, I think has the best promise. It's small, it's portable, the technology isn't quite there yet, but it could be in multiple ambulances. And then you can also do blood tests, but we haven't just found the right blood test. What we have done is we've moved telestroke into the ambulance. So this is a project that I worked on with Wellington Free Ambulance, and we are kind of the leaders in the space globally. And we've mounted these telestroke units in the ambulance so we can see the patient in the ambulance, and we can, how I showed you that picture of the brain and fitting it to blood vessel territory? Turns out neurologists are really good at that. And when it matches with a stroke syndrome, we can be pretty confident it's not a bleed. It's more likely to be a blood vessel problem. We can predict the treatment. And so we're not good enough to treat in the ambulance, but we can make treatment decisions about which hospital does the patient go to. And we can be ready when we meet them at the door to go straight to CT and treat immediately. And we've just done our latest evidence, our latest data, and our median door to needle time, which used to be 90 minutes, has kind of moved down to 60 minutes. With that technology, it's 20 minutes. So it massively speeds up treatment. And then there's advanced neuroimaging. So here's the CT scan that doesn't tell us very much. It's very hard to know whether there is actually stroke. We're relying on just knowing our neuroanatomy really well. But now we have CT perfusion. So what CT perfusion is, it tells you how much blood flow and at what speed it goes through the brain. And if you have a blockage, it eventually gets there through a roundabout way, but it gets there later. So we see there is blood flow, which means it's not dead tissue, but it's blocked blood vessel upstream, and it takes a while to get there. So volume is there, but it's slow to get there. And so we know it's a stroke, an ischemic stroke, and the brain tissue is still salvageable, which is hugely important for us, because with that knowledge, we're no longer married to time. I told you 4.5 hours to treat a patient. We can now treat up to 24 hours. Just was updated 2 weeks ago in the Australia-New Zealand guideline. We can now thrombolyze, give clot-busting medication up to 24 hours. And I did the first patient in New Zealand 2 weeks ago, and she walked out of the hospital the next day. That is very rewarding, especially for those rural patients who take a long time to get to hospital, or when you're waking up with a stroke. This is newer technology called MyStar, which we have at Wellington Hospital, which overlaps it for you. Like you look, the green stuff is the salvageable brain, the red stuff is the brain that we cannot rescue. And we want to have a mismatch of 1 to 2. So there should be enough left that the intervention helps, because if too much is gone, we actually increase the risk of bleeding and complications. And then we get to even more novel technology. So we've just been successful with an HRC grant very recently through the AI RFP, and we now have this tool called Stroke Viewer that we're just imminently implementing in Wellington, so first hospital in New Zealand that's getting this, which gets us not only how much brain tissue is still salvageable, it tells us, is there a blockage, which is really handy when you don't have a radiologist around, is there a hemorrhage, and it can help us predict the outcome of the patient. It also has a chat function for the doctors to talk to each other real time, which is kind of like Teams, but it's handy to have it all in one go and compare images, because we're working a spread out team across multiple hospitals and multiple specialties. So we're trying to get that implemented in multiple hospitals and see how much impact it has on workflow and speed and treatment rates, to see whether it's warranted for the government to invest in this, because it's obviously more expensive long term. So we're working with government on that. So just a couple of words on AI. So AI, from a clinician perspective, it's a complete game changer. So these tools, so imagine you're on call, and every year there's new images that get added. So when I look at images, so if you rock up to an ED, I look at 3,000 images at night. That is a massive cognitive load. And I have to weed through all of that. What AI does, it points me to some things I should take more note of. I look at all of them. I look at everything that it tells me to, but it helps me deal with a complex problem faster. And it's always human oversight. Now there is this concern about exacerbating inequities, because we base these algorithms using machine learning on existing data sets, and they tend to come out of Europe or North America that may not represent our population. And we know women don't sign up to clinical trials, and minorities don't sign up to clinical trials. So there is this concern, somewhat theoretical, but it is definitely something we need to look out. By continuously basing our work on data from historical patients, we may widen the equity gap. I don't have time to go into more detail on that, but it's just a concern that you should be aware of. There's obviously data security issues with these things. We don't really know how the machines do it. We don't quite, like my TIA tool, I built it. I know, although I sometimes forgot how it worked, but like you kind of know how you do it, right? It's logical. It's a mathematical model. Machine learning is less clear. So we don't have as much insight. But ultimately, they go through the same approval as other things. And I think my current biggest barrier is with getting this tool into Wellington Hospital is the Te Whatu Ora's fear of the public hearing we're using AI on them. And so I just want to make the point, we're not using ChatGPT, we're not using generative AI, we're not using anyone's data to inform the algorithm. We're not giving anyone's data to anyone else. We just use machine learning on other people's data to help treat the person in front of us. So I think people need a bit more education about what AI is and the different kinds of AI there are. So this is just a different kind of mathematical algorithm using machines to support the development. Okay, now just lastly, a few more slides, coming back to that Regions Care study I talked about. I did a lot of talking about geographic inequity. I haven't said much at all about ethnic inequity. And so the work we're doing there, and when you think innovations, you came here for the tech talk, right? And hopefully I've given you some tech things, but there are other innovations. And probably the most innovative thing I've done in the last 2 years is engage with rural Maori communities and really listen and meet and create a project with a Maori co-PI who is guiding me from a cultural perspective and who's supporting me. So I went to Northland, I went to Tairāwhiti, Wairarapa, I went to a few other places. We created a research group that is more than 50% Maori researchers, has consumers in it or people with lived experience, they're all Maori. And we developed focus groups or project groups. We listened to their stories, we did priority setting, we identified what they wanted us to fix. What do you want us to work on? What would be meaningful? What would make a difference? What do you think would improve your outcomes? So the Wairarapa group, we developed a booklet together, a patient journey booklet where the doctor can put personalized information in explaining their stroke with some local natural images, and it's Te Ao Māori, preserving tikangas, had a health literacy review. We've also introduced rongoa services in Wairarapa Hospital. So if you go to Wairarapa Hospital now and you have a stroke, you're offered rongoa, which is traditional Maori healing. We've just started. We've had 2 patients. They're both Pakeha, and they loved it. So they had like spiritual healing. They had karakia, waiata, mirimiri with a massage. We're not doing herbals at the moment because we're not quite sure about the interaction, but it's so far very popular, although small numbers. And then in the Tairāwhiti group, some of you may have seen these faces in our Stroke Aotearoa FAST campaign. That's Dolly, Michael, and Colin. They're in our focus group, and they've been the face, at least in that area and more abroad, of this year's FAST campaign. They wanted to do their own videos. Everyone said, use actors. They can't read a script. They didn't read a script. They just came up with what they wanted to say, and it was brilliant. And we worked with a local Maori movie maker who understood them, who picked the right situations. It was long going, and it was a little bit tough, and this project has been hard, but it was very rewarding, the output. And they're so proud, and they're celebrities now in their communities, and it's put stroke into good light. They've all had strokes, they tell their story, and people talk about it. And we created a t-shirt specific for relevant to the Maori with the tohu. This work has kind of exploded onward. Now I'm also sort of this this indigenous stroke person. So I just gave a lecture in Barcelona on stroke and indigenous people. I met all these wonderful indigenous scholars from across the world. And more closer to home, I've been going to the islands. And I like traveling, and I really like learning about different cultures. And I think I've always liked it. It's probably why I've moved to New Zealand. You can probably tell that I was born in Germany, not America, which you probably think. Just distance myself from that. So I've visited islands. I figured we need to do stuff close to home. So speaking of regional inequity, we're pretty bad in New Zealand, much worse in the islands. So I've been to Fiji, Samoa, Papua New Guinea, and actually Debbie is here from Papua New Guinea. So I've worked with her there. She didn't fly here from Papua New Guinea. She's up in Auckland doing a PhD. I don't think you flew here from Papua New Guinea. No, good. Coming from Auckland is very special. Thanks for coming. And in January, a colleague of mine, I'm now fanning out with some other people going to Tonga, and next year planning to go Solomon Islands and Vanuatu. You might wonder why these islands, they're English-speaking islands with CT scanners. So that's where we're starting, and then we're moving out. So we've had lots of workshops, teaching thrombolysis. I've brought nurses along. In fact, Steph, again, sorry, I keep mentioning you. She's coming with me and next week to Samoa to talk about physiotherapy in Samoa. And we've done a lot of thrombolysis training. And in Fiji, they thrombolized their first patient last year. Papua New Guinea, that's just sort of a work plan. I try to do plans for the teams to develop their services, and the first clot retrieval patient in Papua New Guinea this year. So, for my pace was a bit fast, to be entirely honest. I wanted to get the stroke unit care going, but these things are exciting, and they bring news and they bring funding, and it galvanizes the community. And I've back 10 years ago, when everyone thought I was silly about this telestroke thing and doing things like Zoom. You remember Skype, those Skype days. We did this project with Scotland. You might wonder, why are we doing telestroke with Scotland, right? Any idea why? They're almost exactly 12 hours away from us. That means their patients at night present when I'm awake. So we thought, why don't we take advantage of time zones? Now, that was before people were really ready for this. The patients loved it. The doctors were really like, this is a bit dodgy. But we almost had to change the New Zealand law to make this happen. But we're picking it up again and thinking about doing it with islands. So we don't have the time difference, but we exploring treating patients internationally, which is really tricky from a medical legal perspective. There's a lot of ad hoc. In fact, I do telestroke with the islands on WhatsApp. You know, I get a text, I get like a scroll of a CT scan. It's all a bit dodgy, but it's like better than nothing. And of course, they have radiologists there. But, you know, one wonders, why can't we support each other across the islands with telestroke? And then this is flight times. So Darwin sends clot retrieval patients from Darwin to Adelaide. So I just looked on Google Map how long the flight times are. So it's 3 hours 45. It's only 3 hours 15 to Fiji. So why can't we ship patients for clot retrieval to Auckland? So there you go. And so we've now developed this South Pacific Stroke and Neurology Organization. Oh, there's an I missing. South Pacific Stroke Island. We needed a vowel. And Neurology Organization, SPISNO. And that's the executive team. There's Debbie. She was there in Vietnam. But we have Saya from Tonga, who's now doing a fellowship in Wellington. So we're trying to do capacity build. Rather than going in and back out, we're trying to develop people to pick up the skills and lead the services locally. So I was in Barcelona last week. A colleague took that. So this is me hanging out with like the president of the World Stroke Organization. And just, you know, this is not just me. This is New Zealand. New Zealand is known for these things globally. And I just think, you know, we don't talk about this. We invite a lot of people from overseas, and we don't celebrate enough. It's not about me. It's about all the researchers in New Zealand and the work we're doing. And I think we should be really proud. So, in summary, strokes are common, often very disabling, but they are highly preventable. So if you heard nothing else, you know, have a healthy lifestyle, treat your blood pressure and your atrial fibrillation, know the signs of stroke. I'm just keeping it simple. Ring 111. And there's a lot of exciting research and development happening. And I think the technology, including AI, is way more exciting than it is scary. You know, we probably all thought that TVs were scary and phones were scary, and think of where we're at now. TVs are a little scary. But, you know, like we benefit from these technologies, and I think we will adapt and make it work for us. So, while stroke is perhaps not a joke, I'd like to change this message that there's hope for stroke. And this just to recognize some people in Wellington. I wanted to add Janice, my wonderful Janice, my assistant, who I couldn't find a picture of. This is how humble she is. But some people from Wellington Stroke Team. And if you felt so inclined to support any of these efforts, I put conveniently a QR code for Stroke Aotearoa if you would like to donate. You can also donate to University of Ottawa. I promise this isn't why I did this, but I thought might as well do a pitch. My husband used to do some fundraising. He said, nobody will ever give if you don't ask. So here I am. I'm terrible at this stuff. So I'm asking. But you know, if you're interested in supporting any of these initiatives, no amount is too small. And I will finish here. Any questions?